Aloha, I am Mark Alexander, Executive Director of the Hawaii Medical Association. Thank you for joining us for today's conversation at HMA, a program which features discussions with physicians and other thought leaders in the healthcare arena. For this edition, we have an update on the state legislative session, led by the chair of the HMA Public Policy Committee, Dr. Gerald Garcia, and the HMA President, Dr. Elizabeth Ignacio. Before introducing our presenters, I want to review the format for this evening's program. We'll begin with a presentation. After the presentation, we'll move to the Q&A part of our program. Those in the room are invited to ask questions directly to our presenters so that we have some active engagement here on site. Those participating via Zoom webinar are invited to submit questions throughout this program by using the Zoom Q&A function. Please type in your questions, comments, suggestions, ideas throughout, and we will feature as many as possible after the presentation and initial Q&A in the room. We'll also have questions that have been submitted previously through our solicitation. We'll end the formal program no later than 6:30 p.m. We want to hear from you, so please email us at info@hawaiimedicalassociation.org or contact us via our website, hawaiimedicalassociation.org. Now it's my pleasure to introduce our speakers this evening. Dr. Elizabeth Ignacio is an interventional radiologist based on Maui, where she has practiced since 2010. She completed both her undergraduate and medical school education at the University of Virginia with fellowships at Georgetown University School of Medicine and Johns Hopkins Medical Institute, among others. She is board certified in diagnostic radiology and vascular and interventional radiology. Active in her specialty organization, she has served HMA as a treasurer and chair of the Public Policy Committee prior to being the president of HMA. Dr. Gerald Garcia, a double board certified pain specialist and anesthesiologist, is the founder and CEO of the Hawaii Institute for Pain. He earned both his undergraduate and medical degree from the University of University of Minnesota. He completed his fellowship in advanced interventional pain medicine at the University Hospitals of Cleveland, Case Western Reserve University School of Medicine. Dr. Garcia is active with the Hawaii Pain Society, Philippine Medical Association of Hawaii, the Association of Interventional Pain Physicians, and of course, HMA, where he is at present the chair of the Public Policy Committee. We are now pleased to welcome Drs. Ignacio and Garcia.
Thank you. Good evening, everyone.
Aloha, good evening, and thank you for joining us here at this legislative update. It has been a really wonderful legislative session. I say wonderful because it's been really great to have the collaboration of so many different physician and provider groups. I have had some wonderful conversations and learned a lot. I continue to learn a lot about all of these special issues. So in that sense, I think I'll always stay interested in legislative work. I'm happy to go through whatever bills folks want to talk about tonight. I'm going to keep my slides brief because I'd like to encourage a lot of dialogue. And I'll go over some of our highlighted bills and bills that are interesting, whichever ones our audience thinks are interesting as well. But there are, some particular ones that I know that we're going to have to touch on and spend a good amount of time on. So we're happy to do that. I'll scroll through this deck of ours and remind you that we have a specific mission here at HMA, and I'm really pleased and excited to be working on this legislative team with Dr. Garcia, who is a very experienced advocate, and remind all of us that we're here all for the same and common purpose: to serve our providers and patients and make sure that we do everything we can to remove all of those legislative barriers and regulatory changes that can really hamper our ability to provide good care. We want to be able to focus on that for providers, for physicians, so that our patients can get good care, high quality and safe care. This is our 2025 legislative priorities for HMA. As you guys know, back in the fall, we survey our members and ask them what are their priorities, what specific topics, trending or otherwise, they feel are important for Hawaii, for our community. And we try to compile them and prioritize them based on interest. We have people rank them in terms of what's the number 1 through number 8 or 10 topics that they find really important for physicians in Hawaii. And so from that, we have these priorities that were already shared, back at the beginning of our legislative session. I think it's important to keep this in mind because we have 3 bajillion bills moving through the legislature all during the session. And as much as we'd like to, we have to be careful with our resources, our time, and make sure that we stay focused on the most important, what we consider the most important legislative priorities for the healthcare system. So I want to just post that so you know that we are not like sort of randomly pulling in the air these topics and deciding, well, this year I think what we really care about are provider protections or so on. So we want to make sure we're also following the national trends. And from that, I'm sure you're aware that prior authorization has been one of the biggest, if not the biggest topics for state and federal legislation. So I can start with that. We can start on this topic, but we're happy to circle back. Like I said, there's 3 bajillion bills that we could talk about. And I could talk all day long on all of these. So I'm happy to spend as much time as you like. But for prior authorization, our principal measures that are moving forward are HB 250 and SB 1449. These bills are similar, and they've slowly become more similar through the legislative session with a series of amendments and such. But basically, they're now at a point where 250, 250 is going to be, it's on this 48 or 24-hour notice. And SB 1449 is going to be going to conference committee. I'd like to, get your thoughts on it going to conference committee and your ideas of what you predict is going to happen in that regard. But first of all, let's just talk about HB 250. All of these are both on prior authorization, and HB 250 is asking for a work group that would be under the SHPTA agency, and it would basically review appropriate use criteria, standards of care, and those that are most commonly accepted by our national organizations so that we can hopefully cut down or cut away a big swath of prior authorizations as not needed, because we're all going to go by, let's say, I'll pick radiology because I'm a radiologist, but say that the American College of Radiology feels like these are the standards that should be in place for getting a CT of the head for stroke. Obviously that's a multidisciplinary thing. You need neurosurgeons and neurologists and everyone involved, but that we can all settle on that criteria and we don't have to look for different criteria for the headache versus different criteria for swallowing problems, that we can all try to be on the same page for those, that the payers can be there as well, and that we can cut away a big chunk of the prior authorization if this work group so agrees and makes that recommendation. That's a big part of what the work group is going to do, but the work group is also going to hopefully review the readiness of different payers to move forward on automation. Automation is a big part of the new CMS federal guidelines that are moving forward, and that will require a lot of, I won't get into all of the technical details of how to make that work, but we want to gauge like what that's going to look like, whether payers are going to be ready to move forward with that. Certainly that'll be a priority for federal programs, but we want it to be able to happen for private payers as well, and private patients. And so, well, that's part of the work group. There's other criteria that we want the work group to work on. Specifically, I would be very interested, whereas our public policy team was talking about, to make sure that we address these other barriers of PA and make recommendations on chronic and long-term conditions and how we can alleviate like repetitive PA, make sure the PA duration lasts longer, that it doesn't expire, that the denials are clear, that there's transparency of criteria and coverage for our patients. All of this is going to be a huge lift in terms of education. So
those were 2 amendments that HMA added.
Yes.
And that they actually adopted through the latest version of HB 250.
That's right.
So, it just goes to show how influential HMA can be. And, if we do the right thing, just, really they go through our testimony and they really make changes based on that.
Right. Thank you for saying so. And
Those two amendments.
yes, and so we basically, when these bills were first introduced, we like put a huge wish list of what we wanted as physicians for prior authorization. We knew we weren't going to get it all, but we knew that we had to put it all on the table and let our legislators know these are the things that are really problems that we would like to try to start addressing. It's been a long road coming. There's a lot that prior authorization was started for that was good that now has evolved to a very bad process. And so we wanted to propose all of this laundry list of things that we thought we could check off one by one and talk about whether we can accomplish that all in one session. Obviously, we didn't think so, but I think it was really good to propose them. So SB 1449 and HB 250 started looking more and more alike in terms of this work group that was going to address prior authorization. It will be a multi-stakeholder work group. It will include providers, it will include patient advocates, and it will include payers, as well as Insurance Commissioner, MedQuest, Department of Health, and other state leaders. I'm happy to entertain any questions about prior authorization. I'd love for this to be a dialogue and hear from you guys about what you consider your priorities for prior authorization. As you guys know, there's like a whole bunch of different problems with it, right? And it's different ways to attack the problem, but it's so complex and intermingled, it's hard to know where to start. And Leighton, please.
First of all, thank you for your work on this. Huge and potentially impactful. What do you want the membership to?
That's a good question. I think just being proactive and really, reaching out to our legislators, that's going to make a difference. I know, Mark, I asked you earlier this morning, now that HB 250 is going to the Senate, was there a need to try to call your senators and ask the membership to do so? And I think you said that.
Right, at this point, there really isn't a need for that. There's no great call to action. And the reason why I say that is because both bills have basically enjoyed universal support in the chambers, which is rather unusual for this kind of legislation the first time around to have this much support. Now, we shouldn't read too much into that either, because now we're moving into a real delicate situation. It's kind of a little bit unusual that we have both a House vehicle and a Senate vehicle both going to the full chamber. They will likely go to conference committee. So as Dr. Garcia mentioned, HB 250 is 48-hour notice. And so what happens is once a bill is passed by the final chamber, usually, by the final committee, the whole chamber has to have 48 hours to review the bill. Now, when it gets passed, that version gets transmitted back to the originating chamber. And they can say, hey, we agree or disagree with the changes that were made. And so in the case of SB 1449, the House already said we disagree. So then it will go to a conference committee. The conference committee is where everything goes to die, we say, okay? Because so many bills can end up there, even though already, obviously the over 3,000 bills that we started with have been whittled down to several hundred. But in the conference committee, there'll be conferees appointed from both the House and the Senate. Only conferees who voted in favor of the bill can be appointed to the conference committee. And so the conference committee then will decide whether they'll hear the bill, they'll work on drafts of it. There's no testimony that is allowed, but people can communicate with their legislators. So right now, the best thing we can do is for people to contact their own representative. Like, for me, I talked to my representative, my senator, and my rep, and I already have talked to them multiple times as a private citizen, as well as talking to all of the senators and representatives representing HMA to communicate, my thoughts and what I would like to see done. So that's what's important, because we want our physicians to be in a relationship with their legislators. So the legislators know, hey, Dr. So-and-so is one of my constituents. She votes, and I need to pay attention. But we want to express gratitude. I think that's very important. The legislators have done a lot of good work We're not there yet. We have a long ways to go because of the conference committee, but gratitude goes a long way because they've had a lot on their plate, but they've prioritized prior authorization.
Anybody in specific that we should express our gratitude to?
Well, first and foremost, to your own representative senator. Then you want to, of course, the chair of the House Health Committee is Representative Takayama, Greg Takayama. The chair of the Senate Health Committee is Senator Joy Sam Buenaventura. So those are kind of major movers. But, you know, you also have, you know, other people that have been, you know, really important. And we have those folks represented. When you go to the bill, you'll see who authored the particular legislation. For example, a Representative Lisa Martin, who's from Kailua, has been very helpful on prior authorization. And that's really important because she, being from Kailua, where they have a lot of good healthcare services, she can be a real strong advocate for the rural areas who don't. And she is very sensitive to those needs.
And I'll add to that, you know, in terms of what we can do, what our members can do, I'm so grateful, you know, adding to that thought of gratitude, of expressing gratitude. I'm so grateful for our public policy committee who remain involved, who are looking at these measures closely and giving direct and specific feedback about certain sections of it. I'm so appreciative for some of the advocates that I see in the room with us right here, who I've been able to call and say, so, you know, what do you think about the whole, what if we do something for PA duration, or what should we do about denials? And understanding where the different medical specialties and medical fields feel about different parts of prior authorization. As you guys know, like, prior authorization is very different for like a specialist versus primary care, but it doesn't mean it's any easier for anybody. Everybody struggles with it. Some of us have a harder time. For example, I know that in oncology, they're just like, you know, this whole concept of having to renew the prior auth every year for patients who have chronic conditions and long-term disease, that is really very much a chore. And it's unnecessary when we know the patient's condition is unchanged. So that can be a very different kind of prior authorization barrier than for those folks who are having to do prior authorization for, say, a condition that they have specific criteria, they've listed in it as such, but then they're, and I'll use your pain specialty as an example, and you know that you've got it documented right from your specialty, given the time they've had physical therapy, how long have they had this pain, et cetera, but then they're using criteria, it's a black box, the payer is using a different criteria on how that they're going to allow you to get that MRI or not. And so they're saying, well, according to the neurologists or according to neurosurgeons, and it's not the same problem and it's not the same assessment that you're doing. So hearing from the different specialties and different primary care about what you guys think is important, what you consider the priorities of prior authorization reform are really important. And I would encourage everyone to keep in touch with your advocates of your specialties. We have a great HMA council that represents some of the specialty societies as well as regional, for Big Island, for Maui, for Oahu. And let us know what you think about the bills that are moving through. I'm so excited to see the testimony that's there, but we'd love to hear from you beforehand and know that this is a barrier that's really difficult for you, for a pediatrician versus an OBGYN. So that's my addition to your question there.
Plus the fact that prior auth, you know, has become central in a central topic of conversation. I think it's putting a lot of these payers, insurers on notice that, you know, public sentiment and the legislators, you know, there's like this almost like an uprising of some sort, not necessarily against, you know, prior authorization, but hey, we're watching closely. Because one of the biggest barriers for a lot of physicians is that prior authorization can become a very opaque process that a lot of insurers can potentially take advantage of. So we don't really know what's going on or what the criteria is for for one insurance company versus another. And
How
even
did it
that
change?
for
Yeah.
for the same service. So if you want, I order MRIs of low back, I do a lot of pain, spine mediated pain. And the criteria for one is very different from the criteria for another. One can be as nitpicky as like, I need to know how many sessions of physical therapy did this patient undergo and what those dates are before I will approve your MRI. And your most previous note wasn't that specific. And so you have to bring the patient back, et cetera. And another one can just be like, oh, you just need to mention that you did physical therapy. So that is the importance of this working group, because it eliminates the opaqueness of the prior authorization process. The working group can kind of standardize, and that's actually, Lisa, you put that in your addendum, that you wanted them to standardize, seek transparency, come up with an agreement for the most respected clinical scientific standards. And that's what we need, so that everybody is on the same page and nobody will take advantage of the fact that we don't really have the data, everything's such an opaque process. And so that's what this HB 250 and SB 1449 is doing for us. It doesn't seem like a lot from when you read, when you're reading it from, our perspective, because we think that so much change needs to happen in prior auth, but really it's a first step in the right direction. And that will lead to a lot of more meaningful change, but we're just gonna have to, be patient.
Thank you. And from the room or from online about prior authorization or the bills, any questions?
No, not yet.
Further?
Maybe some of the other bills.
Sorry. Yes. Oh, good
The
question.
conferees have not been appointed yet. So that could be a few days or next.
So will the public know?
Yes,
about that?
they
And
will.
then are we then encouraged to call these conferees, or are they off limits?
No, I think one of the things HMA members have access to is our dedicated webpage with the legislative updates. And when you access that, it'll give you the information when you click on the spreadsheet, the specific bills. It'll give you the up-to-date action that's going on. And maybe a little bit later on, I can show the website and how that works. And it'll list the conferees that will be appointed. The House and the Senate will appoint conferees. You certainly can reach out to them. And I think that would be a good thing to do once we have them. Again, very positive, saying thank you for, considering this legislation. We really ask for your support. If there's specific amendments that you would like, minor amendments, then that could be appropriate to make. But the main thing at this point is, because both bills are very similar, there's a lot of goodwill. So we just want to encourage them to finish it up and pass it out. Now, some other bills will be a little bit more complicated. For example, SB 299, which deals with the loan repayment program for healthcare professionals. That is moving along, but they have yet to determine a specific amount of money that will be given to that. So that kind of bill will require a little bit more intervention, maybe, and encouragement. That makes sense.
Go ahead. Yeah, no.
Along the way, and in terms of how they can make that calculation, which includes the fact that
Can you remind me, this is Dr. Carlisle asking the question, and he's asking the question about when HMSA made the comment that X change was going to cost like $70 million. And can you remind me what change that was that they were saying would cost $70 million? I can't remember, but we did reach out and are waiting to hear back why that would be. But the bottom line, can I just, I'll just answer and jump ahead and say, the bottom line is we know that a lot of these costs can cost money. Like a lot of these solutions can cost money. And what we've learned in like the 6 to 8 tenants that are like the foundational tenants for PA reform is that some are going to be more expensive than others to implement or operationalize. So, for example, the gold carding program, that could cost payers a lot of money. So that even though it sounds like a great way to address prior authorization and outliers, it costs a lot of money. So only a few states have actually even enacted any legislation around gold carding, only 2 or 3, when, there have been different, prior authorization reforms going on for the last 5 or 10 years that have been somewhat effective in addressing the problem. So things cost money, we get that, but we understand well that the problems and the increased cost of prior authorization far outweigh those, in our opinion, as physicians. I think we can all agree. So, okay, 70 million, I don't have 70 million on me. I guess that is a lot of money. But at the same time, we have to look at the other costs the other costs of administrative, the burden to our physicians, and the delay for our patients, the increased disability, morbidity, and mortality. So as difficult as it may be, and it might be painful to put that money up, we really want our payers to understand that our patients are suffering. We need to have some changes. So we got to hold that line despite the cost. I wish I had a better answer in terms of what that 70 million was going to go towards.
I think part of the process, should the legislation move forward, and part of the task of the working group is to look at issues like this. In our dialogues with HMSA, for example, we've gotten to a point where there's more transparency than there has been in the past, but we need a lot more transparency with not only HMSA, but the other insurance providers. And there seems to be a willingness to share more information. So we're trying to also, and I think Doctors Ignacio and Garcia have gone a long ways to doing this, create an atmosphere in which we can truly work together. And several of the legislators have in fact commented on that publicly, that they appreciate seeing people working together, collaborating together, rather than creating, a less productive environment. So I think over time, some of these questions will be answered, and no doubt it'll raise other questions as well. But the importance is that we start creating a good collaborative process where all the different elements, our stakeholders, are represented and are treated with equal respect.
But your question is so well appreciated, and we're going to keep the pressure on. The pressure is not just on the payers. We have to all work together to find these solutions. And just as Mark said, we're going to continue to collaborate. We know that the challenge doesn't belong to just one area of our health system. We have to all work together to get this right.
It's a matter of also a meeting in the middle at some point, just as an example. I remember when we first had our conversations with HMSA, I kind of looked at their testimony for these prior auth bills, and it really has softened over time. They came from, opposition without really saying they're opposing it to now a support. And so I think that just coming together with the different stakeholders really does make a difference in advancing this bill.
Yeah.
No,
can
please
do
go ahead.
Yeah.
We'll cover some other bills when we're ready. Sure.
Agreed. And I don't know if you had a chance. So Dr. Carlisle is asking about pharmacy benefits managers. I'm not sure how much is coming up over on the microphone, so I just want to
Right.
restate and wondering, how that might be a starting point, or NIDIS as you used it for addressing the problems from the medication standpoint and the rising costs of medications for our patients. It's a great question. If you were able to see some of those hearings, it was interesting because there was a lot of finger pointing in the system as to, like, is it the private pharmacies that are causing the problem? Is it the corporate pharmacy? Is it the middlemen and the managers? Where are the extra costs coming from? Why can't they stabilize it? And how different areas have tried to, should we as a state try to set some rules and about the money or the budgets and all of this stuff? But that also is a very complex system. And you'll notice that a lot of the CMS guidelines or the new rule that's coming down about prior authorization does not address medications, which is really a problem. So I do hope that we continue that conversation, because it is a huge problem in terms of the cost of healthcare. It is, absolutely will continue to be, even as we address these issues here with cost of care and services from prior authorization standpoint. And maybe from this work group, there'll be some overlap already with how those drugs and drug therapies are handled in terms of payment. I didn't know if they converted that measure that you're talking about to the one that is for the resolution for a working group, but there needs to be physician providers on those work groups. And I didn't notice that was the case. So we're going to have to press more for physician involvement, because it really just only people in that discussion were pharmacists, pharmacy benefits managers, hospitals, and such. So to answer your question with a question, yes, I think it can be, and what our role will be in that, it remains to be seen. But I hope that we will be at the table talking directly with the work group about changes that can help in terms of medications and pharmacy. Does that answer your question?
We can continue the discussion
Yep.
offline, because we're not set up for a dialogue. We're more set up for questions. So I
Yeah.
apologize for that in advance. Are there other
But
bills
let's
you want to review
bookmark that, absolutely.
afterwards?
So, I wanted to just list the progress of some of our measures that are moving forward, and we can go through these. In fact, you can go through these if you want, Dr. Garcia, and talk about them. Yeah, these are measures that we've been supporting. They're all moving forward in some manner. I didn't put all of the resolutions in here, including the patient bill of rights is somewhere at the bottom there, but it's cut off on my slide. But there's also a ton of resolutions that are out that I think are really good as well. So we can start with the cigarette tax. This was a measure, HB 442, and that was going to increase the cigarette tax. Those funds were going to go to the UH Cancer Center in some form. There were different measures that were proposed. There were like 3 or 4 of them at the beginning of the legislative session, and this is the one that's emerged and moving forward. And I think is that the one that we
Yeah.
24-hour notice.
HB 441, it has some challenges because it wants the 4-cent increase to all go towards the carry costs for the development for the cancer center. And so we'd really like to have some of that shared. So 2 cents for the carry costs and 2 cents for the cancer center's important research and academic program.
And we're glad to see that HB 303, the preceptor tax credit, is moving forward. The 1281 was the telehealth measure, and that one got a little sticky at first. If you guys have been following that measure, that's the one that wanted to sunset
107.
107. And we in Hawaii, we've actually had a very progressive policy towards telehealth. And if we were to align with CMS right now, it might cause new barriers to come up, especially for behavioral health, in terms of it would require that those first visits were in person. A lot of the providers may or may not have the capacity to see all of those patients firsthand in person, and it would definitely limit care for rural and underserved areas. So a lot of our stakeholders who we were in dialogue with were just like, yeah, let's try to hold on to our present policy in Hawaii and extend the sunset for 2 more years while CMS policies shake out, and we'll see where we land in the next year or so. There is HB 480, workman's comp. I think that's for functional capacity
Yep.
evaluation. So to make sure that, you know, workman's comp has been such a bear for our providers to handle. And that's the reason why a lot of people don't want to do it. If you talk to anybody who does workman's comp, they just get this very tired look on their faces, because it is a very difficult bureaucracy of paperwork you have to handle for these patients. So this bill actually moves forward the measure that allows for functional capacity evaluation so that you don't have to wait for approval from your employer. You can go ahead and move forward in the patient's evaluation. It's just one of the steps in the process that is taking a lot of time and hopefully will help move the whole process forward for patients who are seeking care. And let's see, the next one I've got there, SB 299, the loan repayment, which is moving forward. And you said that there was some
Yeah,
question.
it still
about
has blanks on the amount of money to be allocated,
Okay.
as well as the commencement date. So that will have some activity in conference.
Transmitted to the Senate. Is that? You said that. Yeah.
Okay. HB 1379, we had a lot of good conversation on this from stakeholders, and we appreciate the discussions we had with the Hawaii Medical Board on foreign medical grads. You know, 1379 is trying to create a different pathway, an alternate pathway for people to get licensure in Hawaii. You know, it's challenging because foreign medical graduates can bring a lot of positivity to a health system. They bring a lot of outside global health knowledge and, of course, contribute to the diversity of culture in any health system. We want to encourage foreign medical graduates, and there have been some interesting apprenticeship type programs here in our state, but to get them licensure can be really difficult. However, us trying to create this pathway has to be in line with national guidelines, and the FSMB, the Federal State Medical Boards, just recently, like literally a couple weeks before the legislature opened, had released their recommendations on alternate pathways. And so it was really kind of a quick and dirty evaluation of that very complex document, which had a ton of stakeholders from AMA, from ACGME, and from all the different programs and directors and leaders. And yet we were trying to move this measure forward. And so it took a little bit of complex conversations to try and get us all lined up and say yes to certain changes in this measure so that it could move forward. I think that these specific criteria, they did move forward with some good amendments from Dr. Takanishi from the Hawaii Medical Board that were presented to the CPC, and those were accepted. So that's moving forward, and that can be a very good positive change for Hawaii, but we want to maintain quality. We want to make sure that we're not capricious, that we're not inventing criteria that we think are good, but are not necessarily in alignment with what's out there nationally. So I learned a lot from this measure and from the discussions that we had, and I'll be interested to see how that goes forward. So where is it? Is it on?
It is moving.
Mhm.
And I think the important thing here, this is the first time in a few years they've had a major discussion around foreign medical graduates. And I think it opens the door to further discussion going forward. For example, whether we look at having site licenses, which certain states have, like Texas, or whether we have special interim temporary licenses for very highly qualified physicians that would be doing specific kinds of work and research here in Hawaii. I think also with the Hawaii just starting with the Interstate Medical Licensure Compact this year, and already we have over 200 physicians that have become licensed under that here in Hawaii. I think we have a number of things that are moving forward, and it could be a good time for good synergy to continue having further discussions so that we can integrate some of our foreign graduates of medical schools better into our systems.
And some of our members here in HMA are also members of the Philippine Medical Association who are very outspoken about this particular measure. Did you have any additional comments?
This is one of their advocacies, actually, and I did go through their I guess, because I'm a member of the Philippine Medical Association of Hawaii as well. Going through their testimony, they just had some amendments that they're recommending, which I don't think has been adopted yet. And one of them was a requirement for a 2-year training of some sort for foreign medical grads who have already done their, training, their residency and or fellowship training abroad and have been practicing for years, and they come here, and do they have to necessarily go through another 2 years of quote unquote residency training? So they're kind of requesting for a pathway, like another pathway where that's not necessary, because that's what everybody has to do now. You could be a neurosurgeon in Italy and come here and have to start residency all over again, so. Go ahead. I think it's just a generic
You might want to
for all
repeat the question.
specialties.
Because
Oh.
You only have the microphone.
Okay, yeah, so Dr. Carlisle was asking if what the Philippine Medical Association of Hawaii was advocating for this pathway, alternate pathway, was for all specialties, or was it for a specific specialty? And I think it's generally for, yeah, all specialties.
Any other questions or comments for the the 1379? We can move on to HB 1194, which is the midwives measure that is moving forward. We really appreciate the collaboration with the Hawaii chapter of ACOG. They've been very instrumental, and they've already had a lot of dialogue with the different midwife stakeholder groups in the state. And for many years, we've been studying this and following this as physicians, but them specifically with the midwives to see like what quality is like after licensure. The auditor's report has said very specifically and clearly that they believe that this is something that should be regulated and that licensure should continue. And HMA agrees with that. And so there have been a number of changes to this measure. Some are great, some are not so great. I won't say that HMA is in complete agreement about some of the amendments. I do worry about scope issues and the maintenance of quality and safety, but I am very glad that we have the ACOG advocates involved and that they are looking at these very closely as well, and they are fighting these bad changes as well. They've given us a lot of instruction, another measure where I've learned a lot.
Yeah.
And so far this was moving forward. There were some changes made, including exemptions. I want to be clear when we're going over this that we all understand as physicians how important cultural competency is. I don't want to throw that out as a rhetoric or, but I want us to remember that we all understand, coming from such a diverse state, that everybody has their ideas about the birthing process, and people should be allowed to have whoever, a family and a mother should have whoever they want there for the birthing process. But if you are providing specific services under a specific title, you have to be careful because there are expectations that are involved and there are safety issues involved, that there's risk in pregnancy and in birth. So we want to maintain standards of care. We want to make sure that attendants that are present in a specific capacity are safe and can understand what a mother or a baby is in distress. So because of the leadership of the ACOG on this measure, we have supported the version that was most recently, not this, I think not the very latest one. We had problems with that one, but the version beforehand, we did support, and we'll follow this closely. This is a contentious bill with bajillions of testimony from community and providers, and pediatric folks have also been very helpful in this. So we'll be tracking this closely. I'm happy to answer some specific questions on it because it's a complex measure.
We have Dr. Goto, who's been
issue
very
here
involved with this
is-
one. She's attending, but she's not available to comment at this time.
Oh, I see.
But,
So ACOG went from literally supporting this at the initial stages of the bill as it was kind of working its way through to opposing it or comments
Yeah.
because of
The
two
last
main
sentence.
issues. One was the PEP pathway, the portfolio evaluation process, which is just kind of like just I think, or it's like a shortcut to getting a license or yeah.
The shorthand of it is it's an apprenticeship type pathway.
Yeah, so it doesn't standardize the whole licensure. And the other one was that invited attendant exemption where, you,
As long as money.
yeah, as long as you're not getting paid, anybody can essentially be present at the birthing.
In a midwife capacity.
Yeah,
Yeah.
so then that kind of, again, was, unverifiable, unsafe. And so these are things that I think, and I looked at the latest version of it that they actually removed and listened to both ACOG and our testimonies. But the point I'm trying to make is this. Your society, whatever specialty you are, it's very important that you try to connect with HMA because, when we collaborate, we don't have, or we usually defer to your society when it comes to bills or, bills or resolutions in relation to your specialty. We usually like to listen to you because you guys are the experts. So for example, this midwife bill, we also went from initially supporting it and then listening to ACOG, listening to their concerns, and as they changed their support, we also followed suit. Had they not come up to us, we probably would have still ended up supporting it, not catching those two little changes in the bill. So I think it's very important that you really work hand in hand with HMA.
This is also a good example of when it'll be important for physicians to get maybe more directly involved with the conferees once they're appointed. Because this bill has gotten a lot of attention, even the Star Advertiser had a commentary on it. And so it'll be important for the physicians to, let the conferees know, hey, as a practicing physician, I really think A, B, and C are really important. So please, consider those changes. I think they'll be very open to that.
Yeah.
Agreed. Thank you. Thanks for those comments. Yeah, I think that was really important to show that we did actually have great meetings with ACOG, and I'm grateful for Dr. Goto who helped connect us and keep us all on track so we didn't get off the rails
Yes.
on that one. All right, and so like I said, there's a ton of measures and resolutions. I didn't put them all on here on the slide, but there is the Patient Bill of Rights, which was SR 20. Actually, there were like two of them on here, and that had moved in the. They're not moving now, and we had supported that. I'm happy to comment on Patient Bill of Rights because we do consider that an important conversation. And we'll see what progress can be made in that regard, if there's going to be a work group or something going on, and we'll press forward on that because we do think that area of our regs, our Hawaii state regs, probably needs a good revision after a couple. It's pretty old, so we'll continue to work on that. Those are just some of the highlight bills, but I'd love to take questions from our group or online if anyone wants to talk about any of these specific bills or any of the ones that are moving or didn't. Any further questions? Oops, did I press something there? Sorry, I think I pressed something on the mic. Apologize. But this is my last slide, and I just wanted to thank our advocates on the public policy core team. And am grateful to be able to tap these folks and ask them questions. And we have so many interest groups. There's too many icons and logos to put on here. It would just wallpaper the whole thing. But I did want to highlight some of our more engaged groups and say thank you to everyone. We don't do this all alone. I'm not some mastermind who understands all of this subject matter. And I am so happy when I can call upon Dr. Carlisle or Dr. Pang and Dr. Grosskreutz and just say, what's up? I know that Dr. Garcia feels the same. I don't know if you have any comments about our team or.
I mean, it's an amazing team. I am not very familiar with a lot of them yet, and I look forward to, you know, getting to know everyone more, you know, closely. But I know that you do interact with them a lot, and even when we talk, you're like, oh, I need to consult with Dr. Carlisle first. Let's try to get his input. And so it's really not, you know, yes, it's us kind of coming up with all the testimonies, mostly you, but it's not just coming from us. You know, we always consult, and we're always very cognizant of the other, you know, stakeholders.
Or, no, okay.
I think we're fine.
Close it
If
out.
you want to make a closing statement, thank you all.
You can. Yeah, I think.
Well, I will go first, and then we
Okay.
end with you. We started with you. So all I can say is, first off, I'm new, and so this is all new, and it's honestly very overwhelming to me because there's a lot of bills, and I really, you know, just the whole process, all the numbers, and it's just amazing how Mark and Lisa can just, you know, just talk about these numbers 441, blah, blah, blah. And here I am just like trying to catch up. But it has been a fun process, and it's amazing to actually see the results or results coming into fruition. So thank you, and thank you, Lisa, for being a great mentor. And I hope we will see, you know, reap the fruits of our labor.
So, hope so. I mean, I'll say in closing, just very briefly, thank you again to everyone who works with us, that I learn a lot. It's exciting. We don't always agree on all of these measures. I gotta say, there's some push-pull sometimes because, you know, some groups may feel strongly about one part of something and we don't agree. That's okay, because what we're trying to do is learn. I think from that diversity comes some really creative solutions. And if we don't hear like the positives and negatives, if that's not pointed out to us, we're just gonna, you know, not be able to have really effective solutions. So I'm just grateful that everybody who is engaged, thank you for being in part of the conversation. Please stay at the table with us, because I think this is an exciting time. I think we've had some really good conversations and discussions with our legislators, with our payers, grateful for that. And I think that those things will only continue and grow. So we'll see what we're not done yet. I'm still very superstitious about where we are here in the legislature, but you know, fingers crossed. And you see me doing that all the time. We gotta hope for the best. Yep.
Want to thank everyone here for joining us for this edition of Conversations at HMA. Special way mahalo to both Dr. Elizabeth Ignacio and Dr. Gerald Garcia for their leadership and for always being there. They are an amazing duo. Really grateful for that. We know that you all have your choice of activities, so we thank you for spending some time with us. This program and the attachments will be available in the next few weeks on our YouTube site. And of course, as always, we just thank you for your participation. We have a long ways to go. The session officially ends on May 2nd. And until then, we will continue to labor together. So mahalo and have a great week.
Thank you.
Thank you. Aloha, good night.